treatment for most of these bleeding disorders, especially the acquired ones, is geared towards the issue at hand. Okay, so the treatment usually is obviously to manage the blood, but there's no like one standard treatment for everything. It's usually geared towards whatever is the cause. So say if it's vitamin C, give them vitamin C. If it's Ehlers-Danlos syndrome, that's the issue, the hereditary disorder, not much you can do about that, but just obviously just control the bleeding and whatever you can do to try to prevent episodes. Okay, so that's that. Now the next one we have is hereditary hemorrhagic Tillaxdasia, also known as Alzheimer's disease. Okay, I know that's a mouthful. I do, however, need you to memorize both names because I'm not sure which one you'll see on a test or in a book. Sometimes different books use different names. But this one is definitely a hereditary disorder. It's autosomal dominant trait. And what happens, these individuals are actually born with very thin blood vessels. So they're born with very, very thin, one single layer of blood vessels. So these blood vessels are weak, and these patients do have bleeding in multiple areas, in very kind of strange places of the body, and I'll give you that in a second. So multiple Tillaxdasias they will have in different areas, so I'll let you know the areas. And so the areas that they will have bleeding, the lips, the palate inside the mouth, and the tongue. So the lips, the palate, and the tongue. They will also have bleeding on the face and the trunk of the body. They will also have bleeding on the face and the trunk of the body. And then the very last spot, which is also strange, they will also have bleeding palms of the hands and soles of the feet. Palms of the hands and soles of the feet. Okay. But I do want you to know one type of bleeding that is their hallmark bleeding is what we call epistasis, nosebleeds. So nosebleeds is definitely their hallmark bleeding. So how do you treat this? Okay, so they do have topical type agents that they can use to obviously control the bleeding. Cauterization is usually very good. Most of the time they use for the nosebleeds. And iron replacement because they are losing a lot of blood. And laser therapy that they can use to, I assume, to attack those vessels. Okay, because if the vessels are thin and weak, it might be better to just kind of get rid of them. Okay. Platelet disorders. Platelet disorders, again, can be acquired or inherited, so we'll go over these. The first one that we have, I think we know maybe about this, is thrombocytopenia. So I'll just go through this really quickly. Thrombocytopenia, we know, is a decrease in platelet count. So sometimes individuals can have where they don't produce enough platelets from bone marrow. So whether that's from a cancer or maybe they just don't produce enough just naturally. Platelet survival. So sometimes when platelets actually flow through the bloodstream, they may not last as long or have a shorter lifespan than they should. Splenic sequestration. Sequestration is a term used for pooling. So splenic pooling. And what happens here, this is a pooling of blood in the spleen. So blood pools in the spleen from different conditions such as mononucleosis and sickle cell anemia. They can have this splenic sequestration. And when blood pools in the spleen, that means obviously blood products are not flowing through, through the rest of circulation. So then they'll also lead to thrombocytopenia. And intravascular dilution of circulating platelets. So these platelets again kind of die off and have a shorter lifespan. You will do your normal blood testing to test platelet count, obviously peripheral smear, and bleeding time as well. How do you treat this? Treat the underlying cause, whatever that may be. So whether it's from a cancer, or whether that person is just not making enough in bone marrow, it has to be addressed whichever way. Now, here are some more causes of thrombocytopenia. I'm not going to have you memorize each and every one of those, but I think we should know already the most common causes. Now, thrombocytosis, this is different. This is now an increase in thrombocytes. So why would this be an issue? An increase in platelets. Very good, blood clots. So understand that we don't want to have too many or too much of anything, but when you have too many platelets, now this can lead to platelet aggregation where they just clump up and make a blood clot. So there are different ways that we can have excess platelets that can occur. So one way is called transitory. Transitory due to stress or physical exercise. So that means when we have, say for example, a person undergoing strenuous exercise, obviously blood flow or blood products will increase, okay, for that time period, which means that platelet count will most likely increase. Okay, so the body will increase blood products because its circulation is increasing. It will do that for that period of time just because of what's occurring. But once the activity is done, then it should go back to normal. Primary, we do have something called polycythemia vera. Polycythemia vera is a condition where a person's bone marrow actually makes too many blood cells. So this is when the bone marrow makes too many blood cells. And then they also have here or chronic granulocytic leukemia, which we also know as CML. This should be, to me personally, kind of more like transitory as well, because when patients have CML, we know they have bone marrow suppression. However, they may make additional platelets to try to compensate, but it's only for a period of time. Okay, it's not like throughout the entire cancer. And then secondary, which is usually the most common part of this, is response to hemorrhage disease process of splenectomy. So these are usually the more acquired ones. Okay, so these are the more acquired. Now, what would you want to do to treat excess platelets? Believe it or not, you want to kill the platelets. I know it sounds strange that you're killing cells, but if you have too many of them, you want to kill some of them to level off, okay, the levels of it. So they do have cytotoxic agents to kill the platelets and some anti-platelet therapies. Thank you. Now, there's another disorder called qualitative platelet disorders. This particular disorder, I want you to know, these are the set of disorders that fall under the category as non-functional platelets. These are non-functional platelets. So the person's making enough platelets, they're just not functioning and doing what they're supposed to do. So these type of disorders can be inherited or acquired. So the inherited disorders are here, so here's the names of them. Okay, Bernard-Soleros, von Willebrand, Tillaxdasia. However, the acquired ones are the ones that are usually the most common. Okay, so these are the inherited ones are not that common, but the acquired ones are more common, which are going to be usually from drugs, and not just, we're not talking about street drugs, but more so pharmaceutical drugs, renal failure, and sometimes hemolytic diseases. And again, treatment is based on the underlying cause. And these patients may require platelet transfusion, which makes sense because it's almost like sickle cell anemia, where we know like the cells are sickled. So when a patient has sickle cell anemia and they have a certain amount of red blood cells that are sickled to the point that they're not functioning, that patient's going to need a blood transfusion. So it's the same situation here. If they have enough platelets that are non-functional, they're going to need a platelet transfusion. And then the last set of disorders we have are coagulation disorders. Okay, so now we're going to go over our clotting factors. So hemophilia is the most common inherited coagulation disorder. Now, it is not the most common bleeding disorder. The most common bleeding disorder, as I told you, are going to be acquired type things, like from medications and things like that. However, inherited disorders are kind of like lower on the list, but when you do see an inherited disorder, they do say that hemophilia tends to be the most common type, okay, that leads to excessive bleeding. Now, hemophilia is broken down into A and B, so there are two different types, and it just depends on the factor that the person's missing. So hemophilia A is a deficiency in factor 8, whereas hemophilia B is a deficiency in factor 9. Okay. Now, they do have multiple bleeding episodes at different places. However, as I told you, hemorrhagic is one of the most common bleeding areas that they have, and so that is their hallmark, hemorrhagic. Now, as far as treatment, one major thing that's important with treatment here is education. Most of the times when hemophilia is diagnosed, it should be or will be diagnosed in children. Usually a person doesn't get all the way into their adult life and realize that they have hemophilia, which means that these young boys will discover this, and so it's very important to educate the parents on proper first aid, how to sort of prevent certain injuries, what to look for when it happens. So those things are important because these children will start to bleed excessively just from little minor trauma. Okay. So how is this treated? They have a particular way of treating this. So hemophilia A, they can use something called prior precipitate, and I'll explain that in a second, or give them factor 8 concentrate directly. So if they're missing the factor 8, they can just give them the factor 8 concentrate. Cryoprecipitate is this. They can take plasma, most likely from a donation, and freeze it. So when you freeze plasma, you're actually kind of containing all of the coagulation factors in that frozen plasma. Okay, so you're able to preserve it that way. So they can give them the precipitate of that frozen plasma. So if you give them the precipitate of it, and I believe this is using an injection, inject it, put it in the bloodstream, you are now giving them the coagulation factors that can help them. Same thing with hemophilia B. They don't have an actual factor 9 concentrate, however, they can give them the fresh frozen plasma, or they can give them the prior precipitate. So again, frozen plasma, they're able to preserve all of those coagulation factors and give it to them that way. They've been using this treatment for quite some time, and years ago I was reading something. They have issues with this because of the donors, and this is before the time they were checking for HIV, and patients actually were developed, because patients that have hemophilia, from my understanding, I think they get this type of treatment kind of periodically. And so before they were checking for that disease, these patients unfortunately were contracting the virus through that treatment. Okay, von Willebrand's disease. This one is a deficiency in factor 8. And so this is a hereditary disorder, and these patients have a deficiency in factor 8 carrier protein, which leads them to excessive bleeding. And so they can have bleeding multiple ways. They do say, I guess you can say this is kind of a hallmark here, but they say that these patients have excessive bleeding during and after surgery. So they'll have excessive bleeding during and after surgery with this particular one. And they do have a particular treatment for this, which is good, called desmopressin. And desmopressin helps to release the von Willebrand factor, and it also helps them release that factor 8, okay, that they're supposed to be having. And they can also give these patients prior precipitate, like the hemophilia patients, and whatever else they need to do to manage the bleeding. Vitamin K. Vitamin K deficiency, I think we would imagine this is acquired. And so what is the link here? Why are we talking about vitamin K? Please understand that the liver, we know, helps make coagulation factors. But we also need vitamin K to help synthesize those coagulation factors. So we do need this vitamin. Okay, so we talked about calcium before, okay, with binding, but vitamin K is also used to help synthesize some of these factors. So if a person has a vitamin K deficiency, it is a possibility that they will not make these factors. So they split it up into infants and adults. So when we talk about vitamin K deficiency in infancy, please understand that most cases of this are actually going to come from babies that are breastfed, surprisingly. And the reason why is because when babies that are breastfed, if the mom is lacking that particular nutrient, the baby's not going to get it. But when children are on formula, formula is fortified with all the vitamins and nutrients, so they usually don't have this issue. So you'll see this more so in breastfed children. If they are lacking the vitamin K, they're not going to make the factors, and so the bleeding that they will have, melena is another term for like saying black tardy stool, so the stool will be dark. So the stool will have blood in it, but it'll be a dark blood. Hematuria, which we know is blood in the urine. They can have intracranial hemorrhaging and hypovolemic shock if it gets to that point. So how do you treat this? Very easy. Give them vitamin K because that's the issue. Acquired vitamin K deficiency. This is more so for adults. Malnutrition. Okay, so if we don't get enough vitamin K and our nutrients. Malabsorption. Believe it or not, when we eat foods, some individuals have absorption issues where you cannot absorb or cross those vitamins across the gut. And we'll get into that when we talk about GI. So people that have, like say for example, celiac disease and things like that, they actually have a malabsorption issue. Chronic hepatic disease, so again, if the liver is compromised, you will have an issue also holding vitamin K to synthesize the coagulation factors. Antibiotics. A lot of people sometimes forget that people that take antibiotics long term, it actually depletes your body of vitamins. And so it's best to, when you're taking antibiotics, and I think we all know to take the probiotics with that, but on the other part of the probiotics is to also supplement, because for some reason it also just depletes the body of our natural vitamins. And then oral anticoagulation therapy, so such as Coumadin. I think we all know and may have heard of that patients that are on Coumadin have to stay away from vitamin K rich foods. So if they are on Coumadin for a period of time, they will start to lack vitamin K, which could possibly lead to this deficiency. So it's kind of like crazy. Now, they will have excessive bleeding. And the way to treat this, give a vitamin K. Now, if they're on anticoagulant therapy, then that's, you have to figure out something else. Okay. Now, DIC. This is called disseminated intravascular coagulation. Okay, I know that's another word that's a mouthful. However, what this means is acute acquired hemorrhaging syndrome that leads to excessive clotting. So excessive hemorrhaging and then clotting. I did see this as one of those NCLEX questions in one of the books, and what they made a point to make you guys understand is that, understand that there's excessive hemorrhaging that starts first. So the hemorrhage is first and then the patient will clot second. Excessive clotting. One of the students a couple of terms ago, I think he was a surgical tech, and he said when this happened to one of their patients, and when the hemorrhaging occurred, not only did the hemorrhaging happen obviously at the site that they were working on, but the hemorrhage happened at different places at the same time. So the person started bleeding from the mouth, from the nose, from the eyes. So it's an excessive overall type of hemorrhaging that happens in the vessels. When diagnostic testing is performed, or I should say laboratory testing is performed, the laboratory test will show results leading more towards the hemorrhage. Okay, leading more towards what's happening with the hemorrhage. And what do they have to do to correct this? Obviously control the bleeding, but correct whatever is the underlying cause. So it can be a number of things that could cause it. Maybe a person has like a chronic liver issue that may lead to this sort of hemorrhagic syndrome. Or sometimes it happens spontaneously. Like we've heard of situations where mothers deliver the babies, they give birth and then have excessive hemorrhaging. So it just depends on what the cause of what happens at that moment. Okay. This is a diagram just kind of going over the breakdown. I don't think we really need this. Okay. Because we're going to talk about shock later on. And the very last thing here is hepatic disease. So really quickly, if liver disease, we know is an issue with coagulation factors. But with liver disease, keep in mind it also impairs that vitamin K because this all goes hand in hand. So these patients will not be able to synthesize or make those coagulation factors. They will have bleeding in different areas, and I told you that the Tillaxdasia is usually the, if you want to say the hallmark type of bleeding that they'll have with liver disease. And so how do you treat this? You can give them vitamin K, because keep in mind that if the liver is damaged, you're not going to be able to absorb that vitamin K. And you can also give them the coagulation factors with the fresh frozen plasma, or give them a transfusion, okay, if they need it, depending on the severity of it. Okay, we're done with this. Okay, let's take a break, and we will come back with, I'm going to do 18 when we come back, okay.